Hello everyone. Today we'll be discussing decubitus ulcers. Pressure injuries that are also termed as bed sores, decubitus ulcers or pressure ulcers are localized skin and soft tissue injuries that form as a result of prolonged pressure and shear force that is usually exerted over bony prominences. These ulcers are present 70% of the time at the sacrum, ischial tuberosity, and greater trochanter, which are the common pressure areas. However, they can also occur in the occiput, scapula, elbow, heel, lateral malleolus, shoulder, and the ear. Besides bony prominences, they can also occur due to medical or other devices such as cell phones. Pressure injuries vary in severity and characteristics. Etiology. So the development of pressure injuries is complex and multifactorial. External and internal factors co-occur to form these ulcers. So externally, the factors that affect pressure sores or decubitus ulcers are prolonged pressure, friction, shear force, and moisture that can lead to tissue deformation and ischemia. Then internal factors include malnutrition, anemia, and endothelial dysfunction. So these factors speed up the process of tissue damage. Decreased mobility, skin moisture, poor nutritional status, and loss of sensory perception stand out as the most common risk factors. So these are commonly seen in what? Chronically ill patients. Prolonged pressure on tissues can cause capillary bed occlusion, reducing oxygen levels in the affected area. Over time, the ischemic tissue begins to accumulate toxic metabolites, subsequently leading to tissue ulceration and necrosis. Immobility of only 2 hours in a bedridden patient or patient undergoing surgery is sufficient to form the foundation of a decubitus ulcer. That's just the foundation of a decubitus ulcer, okay? The dysfunction of nervous regulatory mechanisms that are responsible for regulating local blood flow is also somewhat culpable in forming these ulcers. So when we talk about the pathophysiology, decubitus ulcer formation is multifactorial, but these ulcers result in a common pathway that leads to ischemia and necrosis. Tissues can sustain an abnormal amount of external pressure, but constant pressure exerted over a prolonged period is the main culprit. External pressure must exceed the arterial capillary pressure, which is 32 mm mercury, to impede blood flow. Then pressure must be greater than the venous capillary closing pressure of 8 to 12 mm mercury to impair venous blood return. Sustaining pressure above these values leads to tissue ischemia and necrosis. This significant pressure can result from compression by a firm mattress, hospital bed railings, or any hard surface that is in contact with the patient. On history and physical examination, so a patient's attendant typically reports pressure injuries. So the diagram that you can see on the top shows the common pressure areas. Due to reduced sensation at the lesion site, patients may often be unaware of their injuries. Pus or blood discharge may stain the patient's clothes or bandage, and that's how it may be noticed. The clinical presentation may vary between different sites as skin, soft tissue, and muscle resist external pressures differently. The most common anatomical locations are the sacrum, ischial tuberosity, and greater trochanter. Other areas that are at risk include the occiput, scapula, elbow, heel, lateral malleolus, shoulder, and ear. The muscle becomes ischemic and necrotic before skin breakdown can occur, which can be deceiving to the clinician's observation, undermining the depth or extent of the ulcer. Evaluation. So you need to examine the following: the history of the ulcer, including the etiology, duration, and any previous treatment. Then staging needs to be done by thoroughly examining the depth of the wound, which this activity will cover in detail under staging. So the staging is following after a few slides. Then you need to look at the size of the affected area, any sinus tracts, any drainage, presence of necrotic tissue. When evaluating the wound characteristics, it's also important to keep risk assessment instruments in mind. So the most common risk assessment tool is the Braden scale. It includes 5 sections that are worth 4 points and 1 section that is worth 3 points. Then you sum the points to provide a risk assessment score. So when we look at the Braden scale, so sensory perception is graded from 1 to 4, which is completely limited, very limited, slightly limited, or no impairment. Second is mobility, which is graded from 1 to 4, starting from completely immobile, very limited, slightly limited, or no limitations. Then you look at moisture, graded from 1 to 4, which is constantly moist, very moist, occasionally moist, or rarely moist. Nutrition 1 to 4, which is very poor, probably inadequate, adequate, or excellent. Then activity, bed fast, to chair fast, 3 walks occasionally, 4 walks frequently. Friction and shear, so 1 to 3, problem, potential problem, or no apparent problem. So the scores are, if they're between 15 to 18, that's mild risk, 13 to 14 moderate risk, 10 to 12 high risk, 9 or below very high risk. So the lower the score, the higher the risk. Now let's talk about the staging of pressure sores. So that's from stage 1 to stage 4. So as you can see in the diagram as well, so stage 1 is where the skin is intact with non-blanchable erythema. Stage 2, there is partial thickness skin loss involving the epidermis and the dermis. In stage 3, there is full thickness skin loss that extends to the subcutaneous tissue but does not cross the fascia beneath it. Slough or eschar may be visible and the lesion may be foul-smelling. Then stage 4, full thickness skin loss extends through the fascia with considerable tissue loss. There may be muscle, bone, tendon or joint involvement. Then it may also be unstageable, whereby the depth is unknown because of slough or eschar that obscures the extent of tissue damage. Then deep tissue injury is another category that is mentioned. So this is whereby the injury occurs with prolonged pressure and shear forces at the bone muscle interface. The result is intact or non-intact skin with persistent, non-blanched, deep red, maroon or purple discoloration. Deep tissue injury cannot be used to describe vascular, traumatic, neuropathic or dermatologic injuries. So treatment or management of decubitus ulcers. So what you need to know is emphasizing the prevention is the best treatment. So prevention consists of maintaining and improving tissue tolerance and appropriate offloading. So how do you achieve that? It can be achieved through excellent skincare, adequate hydration, pressure dispersion, cushions, turning schedules, which we commonly say 2-hourly turning, and support surfaces. After forming a pressure ulcer, actively offload the affected anatomical area, ensure adequate drainage if an infection is present, debride devitalized tissue, and provide optimal wound care. Then how do you redistribute pressure? You do that through active patient repositioning, immersive beds, special dressings, and refitting prosthetics for offloading. Then if there is an abscess that is present, drainage needs to be done. Antibiotics should only be an option if significant cellulitis or systemic signs of infection are present. Mechanical debridement is usually necessary to remove devitalized tissue and biofilms that prevent wound healing. However, the above is not recommended if there is a dry eschar without purulence or fluctuance. The dressing varies according to the stage of the ulcer, absence or presence of infection, and presence of exudate. Complications. So the most common complication is infection. Grade 3 and 4 ulcers require intensive management as their complications can be life-threatening. Microbial analysis has shown that aerobic and anaerobic bacteria are present in the lesions. If the infection spreads to deeper tissues and bone, periostitis, osteomyelitis, septic arthritis, and sinus formation can result. The invasion of the infective agent results in fatal consequences because septicemia is challenging to manage in an already debilitated patient. Chronic decubitus ulcers can cause chronic anemia or secondary amyloidosis. Anemia can also occur secondary to chronic water loss and bleeding. So that's all about decubitus ulcers. Thank you.